Thank you very much. It is a pleasure to be here and very exciting to participate in this process, which I think is absolutely necessary to bring chronic fatigue syndrome, ME, into the mainstream of the medical community. The CDC recognized the importance of the question of case definition and started on this process before there was the IOM committee concept. And not only CDC, but people worldwide have done various surveys and discussions with clinicians. And it's clear that physicians worldwide recognize an illness that is called CFS or ME, there's more similarities than there are differences in the case definitions and how this illness is described. However, the illness is very, very complex, and the patients are very heterogeneous. And the heterogeneity of patients in clinical trials and in research studies and epidemiologic studies where we try to establish risk factors certainly can confound results. And this may be contributing to really the lack of uniform forward motion in studies of this illness. And I've just listed some of these that really do contribute to confounders or the heterogeneity, not the least of which is the duration of the illness, the severity of illness, the types and the numbers of symptoms that each patient experiences, which conditions or symptoms are comorbid and which are separate, what medications patients are on, and I think the medication question is probably one of the ones that has been least investigated and could be really potentially most problematic for understanding this illness. And of course, demographics that would be true for any illness, such as age, race, sex, body mass index, socioeconomic status. So with these different case definitions in use, this is not unique to CFS or ME-CFS. There are many different illnesses that have different case definitions, and sometimes they can be used for different purposes. And the problem is when people don't understand the differences and how to use them. And clinicians need as clear and as simple a message as possible so that this illness is recognized and patients get the care they deserved. And one question we need to ask ourselves, and CDC we ask ourselves when we put this study together, was whether really refining or adding criteria was going to give us this homogeneous population that we wanted. And finally, also asking from a clinical perspective, what do you do with patients that don't fit any one particular definition? And so right around this time, there was an article in Nature Reviews of Neuroscience, and Dr. Komaroff and Dr. Holgate gave what I thought were interesting perspectives. They said that call CFS-ME a single disease greatly underestimates the complexity of the problem. Thus, to look for the cause of CFS-ME is a self-defeating exercise. That was one. The other one, I suspect that none of these case definitions is likely to describe a very homogeneous group of patients. And I think that is a very interesting starting point. And so we took this to heart and thought that perhaps case definition alone wasn't going to be enough to get us where we wanted to go. And we thought that we needed to examine how we could measure and really truly characterize this illness as carefully as possible. And so our study objective was to really go back and capitalize on the clinical expertise of physicians who are experienced in the care and treatment of CFS patients. And I'm using the term CFS, but we made it clear to the clinicians participating in this study that patients that they managed as CFS, as myalgic encephalomyelitis, as post-infectious fatigue, any of these synonyms or possibly related illnesses were eligible to participate. We then hope to use standardized data collection form on all the major domains or parts of the illness and to describe what the patients in these clinical practices actually looked like. And so to provide data both to address how case definitions might work, as well as to identify subgroups that we could find from these patients. The enrollment criteria we developed in collaboration with the clinicians who are in the study, and we agreed that any patient 18 to 70 years old who had been diagnosed or managed in these clinical practices, again, I'm using CFS as the shorthand, was eligible to participate. The key feature of this is that the enrollment criteria relies on clinical expertise rather than on any one case definition, because you can end up with a chicken and egg kind of problem when you require a specific case definition for people to enter a study if you want to examine questions about case definition. The clinicians agreed that the only exclusions that they wanted to include were patients that were HIV positive and if the patient was older than age 62 years at diagnosis. This is a list of our participating clinics. We have three. This is done through a contract mechanism. We have 3 contracts. One is with Beth Israel Medical Center in New York City with Dr. Benjamin Nadelson. Another is with the Institute of Neuroimmune Medicine with Dr. Nancy Klimas. The third is with the Open Medicine Institute Consortium, which includes 5 different clinics. The Fatigue Consultation Clinic with Lucinda Bateman, Hunter Hopkins Center with Charles Lapp, Open Medicine Clinic with Andy Kogelnick, and Andy is the organizer of the Open Medicine Institute Consortium, Richard Podell Medical with Dr. Richard Podell, and Sierra Internal Medicine with Daniel Peterson. And we were very pleased that we were able to interest these very, very experienced clinicians in participating in this study. So as I sort of hinted, the protocol was really developed not by CDC alone, but by the clinicians in partnership. We wanted the data collection to fit into the clinic routine as much as possible and to minimize the burden to the patients. Now, it is a burden to the patients, but we wanted to try to make it as simple as possible. Of course, the protocol was IRB approved. And what I'm going to be talking to you about is really what we call our stage 1, which is the first year data, which is cross-sectional. This included a physical examination at the time of the clinic visit, or if that was not going to be done at the clinic visit, if there was a physical examination available within 1 year prior to enrollment. There were questionnaires for the self-reported measures of illness that the patients completed. And then there were data abstraction medical records by clinic personnel. The data abstraction forms, a lot of these are not standardized, but they're very rich sources of data. Each clinic had a new patient intake form, and these were scanned. We do have that data available. We have basic demographics. We have a detailed medical history, and this is abstracted. We asked the clinic staff to do most of the heavy lifting, but the detailed medical history also has a part that the patients complete at the day of clinic. We have the history of present illness. We have a current medication list. We have abstraction of laboratory tests that were done at this clinic visit, as well as an abstraction of data that's available in the record. We have family medical history, infection and immunization history, and then the physical examination. The data collection instruments, again, these are self-reported patient instruments. The first 3 are given at the clinic, but all of the others are available to the patient before clinic, and they're asked to complete them as they are able over the course of a week prior to their clinic visit. And these include something that's called the Cdc Symptom Inventory, which is, we just made it up, so that's why we called it that, but it is an inventory of all of the major symptoms, a medical outcomes form, short 36 items short form, the multi-dimensional fatigue inventory, questions from the DePaul Symptom Inventory questionnaire, PROMISE forms. Now, PROMISE is an NIH initiative that is developing very standardized questionnaires of illness domains that could be applied to any illness, and we thought that was important to include. Sleep questionnaires, as well as a brief pain inventory. Now, our data collection and processing, the questionnaires, as I indicated, the patient self-reported questionnaires were given to the patients prior to them coming to the clinic, and it was given in two different ways. For some of the clinics, they were actually mailed a packet of paper forms, and the patients completed them as they were able at home. And in other patients received actually a website where they could go online and answer the questions on all the forms. The paper forms were scanned and sent to an FTP site at CDC, and the online data sets were sent as Excel files to CDC using the same FTP site. Now, I will say that the questionnaires were, there are quite a few of them. There is some overlap in the questions that was intentional to help us understand which measures, how they correlate in identifying the aspects of the illness. So there was a little bit of redundancy in the way questions were asked. Clinic personnel occasionally had to call and help the patients walk through the forms, answer them, so they were not completely done independently. The data at CDC was cleaned and underwent QC by CDC personnel. For those forms that were scanned and entered, we had a 10% accuracy validated in 10% of those. And then we had used other general descriptive to check the data, including the out-of-range, outliers, and extreme values. For those instruments that have a standardized scoring system, these were scores were calculated and verified by a triangular approach. And then we have started doing descriptive statistics and comparison of related measures. And so our study sample includes data from 471 participants. And these participants were considered satisfactory for analysis if we had all of the forms completed with at least 80% of the data there. And the distribution among the 7 clinics, we got a pretty good even distribution. Our overall patient demographics, the mean patient age was 48.2 years. What is shown there is a distribution and probability plot of what the population looks like. They are almost 3/4 female, 90% white. The mean BMI is 26.2. Over 77% have a college degree or higher. 94% are insured, and 75% are not employed. This shows the illness onset and duration. The mean age at diagnosis is 38.4, and 65% overall in that population had a sudden onset, although this did range in clinics. Some clinics had a slightly different proportion of people with an acute onset. The mean duration of fatigue was 14.3 years, and again, you can see the distribution of the duration of illness. It ranges all the way from 2.5 to 52 years. So just a few comments on this study sample. These were specialty clinics in CFS, and the patients in these clinics may not represent the entire CFS-ME population of patients in other healthcare settings. These patients had a very high educational level, high socioeconomic status, and they were largely insured. They also had a very long duration of illness, although when you look at the population, at the distribution, there were 80 patients with a duration of 2.5 years or less. So we do have a small set of relatively newer onset. And finally, this is a referral population, and most of the patients have been evaluated and seen by more than one physician. So just quickly, a little bit to give you an example of how the data can be used. We have measures of fatigue in the PROMIS scores, as well as in the MFI subscales. And this shows how the PROMIS fatigue correlates with the general fatigue, physical fatigue, and reduced activity subscales of MFI, and not as well with the reduced motivation and mental fatigue. Again, a population distribution of the MFI scores showing general fatigue. The higher score is worse, showing a ceiling effect. In other words, it's not really giving a good range. In the SFI, again, mental health is relatively preserved, and the other symptoms, again, this is a distribution. In addition to the SF36 scores, we had questions on daily hours of activity, either in a vertical position or in a horizontal position, meaning either sitting, lying, as well as questions on numbers of exercise per week. We have measures of pain using the brief pain inventory as well as the PROMIS scores, and these show a very good correlation. Cdc Symptom Inventory, again, some of the major symptoms that have been reported are scored, and the higher the scores, the worse the symptoms. And again, post-exertional malaise, unrefreshing sleep, memory and concentration are among the highest. And finally, just a little example of how important the PROMIS scores are. This shows how PROMIS scores from CFS can be compared to PROMIS scores from other illnesses to put them in the context of the same idea. So for example, chronic pelvic pain, spinal cord injury, muscular dystrophy, post-polio syndrome. And you can see that how the fatigue and the sleep and the pain in CFS patients compare to these other illnesses. And finally, I would like to close with acknowledging the patients that participated in this study in our phase 1, as well as those that are continuing on in our other studies, the clinicians and the valuable research staff that they have enlisted to work with them, and the great people at CDC who have contributed to this. Thank you.
Thank you very much.